Hey guys, welcome back to Blackwood Vascular. This is a simple video that I am going to be making showing what an endovascular stent graft looks like after it's been placed in the body. So here you have an aortic aneurysm which has a kidney artery to each side, as you can see, and a stent graft has been placed in. We're looking at it from the inside with the aneurysm cut wide open. So this is all a blood vessel, and blood vessels have branches, as you can see, to the right and to the left, and then the blood vessel splits into blood vessels that go towards the legs, and even another further split here that goes towards the pelvis, and to that side, to the other left leg. Now the physician has placed a graft, a stent graft. It's a fabric made of usually PTFE, which is polytetrafluoroethylene, and has nitinol metallic rings to reinforce it, to keep it, somewhat rigid, sort of like a spring, so it stays open and always tries to stay in an open position. And basically what you're doing is you're not actually fixing the aneurysm like in the old days where you'd actually cut the aneurysm right out and sew a new graft in. Instead, what you're doing is basically putting a graft in and excluding the aneurysm. And look at that. The company here, Gore, actually named their graft the excluder. It's kind of interesting, actually. So anyway, why I wanted to do this video is because last night there was a patient who they called me thinking the patient had a rupture, and this is happening far too commonly, and not the patient's fault in any way, but this is just education needed from the physician side. But because the blood vessel has branches, and some of them are not even seen here, they're usually branches coming right off of the aneurysmal portion, maybe behind the graft here, what we call lumbars, which feed the muscles of the spine and back, and also the spinal cord. But basically, if you were to consider it as a blood vessel, you can imagine that there are areas where there might be branches that might stay open and blood could return into the sac, into that clot. Well, right now it's all full of what looks like a clot there, but imagine there was a side branch coming right off of right here. Then you could imagine if it was connected to the main blood flow up above, you could have flow coming back into the lumen. So I don't think I can mark this up, but in either case, why don't we go ahead and just watch this video real quick. I'll put you there. And what I'm showing you here is up at the top there is where blood is coming in but can leak around the sides of the graft. So you can imagine some blood leaking right through that gap if the seal is not very good. And the seal might not be very good because sometimes the graft is the wrong size. Sometimes the artery is taking a turn in that area. Sometimes there's a big lump of calcium or clot sitting in that area. So you never know, but for several reasons you can get what's called a type 1 endo-leak, where imagine your blood pressure when you check it with your cuff is 180 millimeters mercury. Then 180 millimeters mercury pressure can leak right through that little gap along the side of the graft here, between the layers of the original blood vessel wall, and then enter the sac and pressurize the sac, causing it to continue to expand over time. So that's a type 1A endo-leak, and the same exact problem can happen at the bottom if blood comes down and then goes in between the limbs, the side of this right leg, between the outside of the graft and on the inside of the blood vessel. It's not on the outside, it's not a burst blood vessel. The blood vessel is still intact, but now you have blood tracking. You have just like fluid tracking between where the graft is trying to touch the wall of the blood vessel. So now you no longer have a protected aneurysm, right? Because the whole point was to exclude the aneurysm with this excluder graft, but now you would have a situation where you have a leak happening around the graft, and every single graft no matter what brand it is. There are five or six major manufacturers within America and some additional ones in Europe and China. But Gore, Medtronic, Cook, Endologics, Terumo, all of these grafts, Bolton, they all have leaks that can occur. This is not a phenomenon that's related to any specific graft. This is just a multitude of factors that go into play. So there is another leak I want to show you, which can happen, and that would be if the graft, if you were to imagine the graft was placed in multiple pieces. Well, right there, that gap, you can have a leak happening in between where the top limb and the bottom limb are connected together. And remember, this is not magic. So fluid, imagine you did this in real life with just water. Water would naturally leak out if you were to put two of these grafts together. What we hope is that in the initial placement, everything is pretty tight. And as time passes, these leaks, within even the time when you're on the operating room table and shortly afterwards when you get to the recovery room and your blood thinners slow down, or even if they don't slow down, your blood naturally forms little clots and then eventually seals up those areas. So leaks are not uncommon. Type 1, and this is the other high pressure dangerous leak, which is called a type 3 leak. There are other types of leaks we can talk about in a different video, but I think I would need additional pictures to show you. For example, a type 1 is a leak from a high pressure leak that happens from the top of the graft or the bottom of the graft. A type 2 leak is a leak that happens from a branch, which we don't have a branch in this picture, so we can't see it, but it would come right back into the sac. It's usually a low pressure leak. It's the most common leak, and it's unlikely to cause any sac expansion immediately, but it should be watched and followed, and you should go see your doctor and get surveillance and all that stuff, and make sure you're getting your CAT scans. Anybody who has these grafts in basically should be checking in with their doctor every single year until you die. You are not fully repaired if you have a minimally invasive endovascular repair. You forever are at risk of re-expansion and a leak forming. And if you just think of it that way, then you're doing the safe thing, and you'll go and see your doctor. And maybe one day you may never want to see your doctor anymore. People who are in hospice, they don't have to go see their doctor. People who are no longer interested in having surgical procedures, but the point is that for the most part, if you had an open surgical repair, you should still see your doctor and follow up with your vascular surgeon yearly, but you don't have to follow up with the kind of rigor and fervor needed, because at the end of the day, you actually have the aneurysm cut out. No, you can still form new aneurysms elsewhere in the blood vessels, but that's follow-up just for general follow-up reasons, not because you actually are still watching the same aneurysm. After these grafts are placed, normally what would happen is that the aneurysm will either do one of three things. It will either grow, which means that there's a leak. It will either stay the same, which means that there might be a leak, and the pressure reduction of having the graft might be sort of in a quasi-stable balance. And the last option is that it can shrink, which means that even if there is a leak, the leak is so small and the pressure is so low that the aneurysm sac is naturally starting to contract down around the graft. And that's basically everything I can tell you about endovascular aneurysms in terms of just with this video of this graft. And I hope this was helpful. So when you guys hear about the fact that you have a leak, you need to know if it's a rupture or a leak. Radiologists should be able to tell immediately, and the emergency room physicians should say. If it says endo-leak is very different. Now, probably the good news is that because all the emergency room physicians are probably going to ignore this video, which is good, it probably means that they'll continue to call us in the middle of the night for random type 2 endo-leaks, which means that my vascular surgeon friends will be like, Stuart, you did a bad job. But the overall population will continue to do well, because we will continue to wake up, check the CAT scans from wherever we are, and come and see the patient and make sure it's not a true rupture. Because I guess if you were to think about it, if you call somebody 5 times and it's always a leak, but they always come. Then the one time when you call them, it's a rupture, at least they'll be there too. So good luck, guys, and uh, you know, just like and subscribe if you care to see more videos like this.